Well, thank you for joining us again and presenting for us today for the second time is Dr. Melanie Hoppers. She's board certified in internal medicine and pediatrics, working with the Bateman Horne Center of Excellence. So I will go ahead and get her slides pulled up.
Thank you.
All right, and can everybody see the slides? All right, looks like we're good to go.
Okay, thank you so much for having me back and graciously allowing me a second chance when I had to cancel the last time. So I was thinking today, I like conversations, and if anyone has a question, I always find I forget my questions by the end. So if you have a question in the middle and you want to ask it, go ahead. Or if you have a patient you want to ask, go ahead. Let's, make this really helpful today. But I want to talk about two of the comorbidities I see a lot in pediatric long COVID, and one is orthostatic intolerance, and one is mast cell activation. I didn't call it mast cell activation syndrome, and I'll explain to you why later, but that's not an error that I didn't put syndrome there. So I am from the Bateman Horne Center. We are a 501c3 nonprofit organization. We provide clinical care, we do research, and also provide education regarding infection-associated chronic conditions and their comorbidities, including, of course, long COVID. Next slide, please. Sorry.
Of course, I said I could do your slides.
That is okay.
Oh, there we go. Sorry.
That's okay. I'll go ahead and go over I have no disclosures to discuss. And next slide. The consent and assent was obtained from patients, and some of the examples I provide are composite clinical scenarios designed to illustrate common disease presentations rather than necessarily a single individual. This is just to try to provide confidentiality. Next slide, please. Our learning objectives today are, I want to give you some practical tools for use with your patients. I want you to be able to recognize orthostatic intolerance and to recognize mast cell activation and have at least some tools in your toolbox to help them. Next slide. And then you can just go on down to orthostatic intolerance, which is and then go ahead and go to the next slide. Perfect. Thank you. So orthostatic intolerance is referred to oftentimes as OI. It's a group of conditions in which symptoms develop when assuming and maintaining upright posture. Now, you obviously think of standing, but this can also refer to sitting with your feet on the ground. And I point this out because in my pediatric patients, one of the things that I see happen is parents will get called around 10 or maybe 12, hey, come pick up your kid. They're not doing well. They'll go pick up the child and they may be flushed and jittery and look all like they're having a panic attack. What's happened is they've been upright with their feet on the floor for the last 3 to 4 or 5 hours. And now it looks like they're having a panic attack, but they're really just suffering from autonomic dysfunction. And so, many of these symptoms are relieved when they lie down. There was a study at the Kennedy Krieger Institute that looked at 91 pediatric patients with long COVID, and they found that 71% had at least one orthostatic condition. So this is very relevant in your long COVID pediatric patients. Next slide, please. So the normal physiology, I'll briefly remind you about this. So when a normal person stands and they're healthy, going from supine to standing, there's a shift of about 10 to 15% of blood volumes. This shifts into the lower extremities and abdomen due to gravity. There's a decrease in central blood volume, stroke volume, cardiac output, and thus cerebral blood flow. So normally what we do, and this is all very seamless, is there is a adaptive response with an increase in activity of catecholamines. You have increased production of norepinephrine and epinephrine. This results in increased heart rate, increased cardiac contractility, and constriction of blood vessels. You get return of blood flow to the brain and the heart, and most of the times you don't even notice. And every so often a normal person might feel a little dizzy when they stand quickly, but for the most part it's pretty seamless. In patients with orthostatic intolerance, there's a maladaptive response to these changes. One, there may be a larger amount of blood pooling frequently our patients have hypermobility and increased compliance in their blood vessels. So the blood pooling is much worse. Additionally, they may have a lowered blood volume. Also, blood vessels don't respond to those catecholamines, so they keep pumping out. The body says, you're not responding, I'll produce more. And so it's, in some patients especially, this is more prominent, and they are almost like they're in fight or flight all the time. They'll come into the clinic and look like someone had jumped out of a closet and yelled boo at them. And, they're even a little tremulous. They may be flushed, but they just look like they're on fire. So next slide, please. Some of the symptoms of orthostatic intolerance, again, the activation of the sympathetic nervous system. It's the palpitations, the heart racing, heart feeling like it's beating out of their chest. They'll have shortness of breath. They may experience anxiety because if you have those symptoms, you're going to feel anxiety. They may have tremors and sweating. They may break out in a cold sweat or have nausea. The cerebral hypoperfusion will elicit brain fog, blurry vision. They may look confused. I find a distant look sometimes when I'm doing the lean test that we'll talk about in a minute. I just notice this far away look in their eyes, but you can tell that they just aren't quite comprehending their surroundings anymore. They may also develop fatigue and myalgia. Next slide, please. So there's some predefined forms of orthostatic intolerance. There's orthostatic hypotension. Y'all all are familiar with that. It's sustained reduction in blood pressure of 20 systolic or 10 diastolic within 3 minutes of standing. Delayed, easy enough. It's after the 3-minute mark and is also sustained. Now, POTS is what we oftentimes hear about. And oftentimes, we're really bad with language, I think. We'll use POTS for orthostatic intolerance when really it's not technically what they have, but you'll hear that term most of the time. But technically, POTS from the ages of 12 to 19, first of all, the patient must have orthostatic symptoms for at least 6 months or greater than 3 months, excuse me. They must not have some underlying issue like dehydration or, they're sick. So that needs to be ruled out as well. When they go through their tilt table test or their lean test or whatever testing modality you use, their heart rate will increase greater than 40 beats per minute within 10 minutes of standing and needs to be sustained, not just one reading and then all the rest are normal. That would not qualify. Additionally, they don't have a significant drop in their blood pressure. Additionally, there's inappropriate sinus tachycardia, orthostatic hypertension, but the one I really want you to pay attention to is at the bottom in red. It's low orthostatic tolerance. And this is where you have patients who have all the symptoms. They're dizzy, they're lightheaded, their heart is, feels like they're pumping out of their chest. They may have anxiety and tremulousness. When you do the test, they don't quite meet the criteria. Maybe their heart rate goes to 30, 35, or their blood pressure doesn't quite drop enough to meet that criteria, but they look like a patient who has one of those conditions. And, if you aren't aware of this, you may chalk them off and say, well, you don't meet criteria. We really don't need to treat you. But next slide, please. There was a study done that Dr. Peter Rowe, and it was actually Van Kampen and Peter Rowe and others did. And what they did is they took patients who had healthy controls, and then they had patients with ME/CFS. There was a group that had a tilt table test, and they tested positive for POTS. And there was a group who had tested positive for orthostatic hypotension, and then a group who had symptoms but had not tested positive did not meet that criteria. So they did another tilt table test, and they measured cerebral blood flow volume. And what they found is on the tilt test, healthy controls had a reduction of 7%. So that's kind of the baseline norm. Those with POTS had a reduction of blood volume, cerebral blood flow volume of 29%. Those with orthostatic hypotension were 26%, and those who didn't meet any criteria were 24%. So, I always felt in my gut that these patients had a problem, but, in our world of objective evidence, sometimes they get dismissed. I want you to just see that there is an issue with their cerebral blood flow, and they do have problems. So I treat them the same as I do our patients who have one of those, syndromes that we call, such as POTS. Next slide, please. Additionally, sitting is an issue. Like I said, in the middle of the day or middle of the morning time, patients will, call home, I need to come home. I say this, I have a patient, or I have a patient, have a daughter with this illness, and she used to call me about 10:30 every morning. And I'd go, well, why are you so anxious? Oh, well, this was why. Because she had ended up having severe orthostatic intolerance, and she was sick because in the middle of the day she'd been sitting with her feet on the floor for so long. But in this study showed that there was a 24.5% reduction with sitting in patients with ME/CFS of their cerebral blood flow. So what do I ask patients? How do you identify them? Well, first of all, if they have long COVID, check them, because again, I haven't had any pediatric patient with long COVID who I did not identify as having some form of orthostatic intolerance symptoms. I have some adults that it's hard, their orthostatic intolerance might be mild, but in kids, it's there. Just go looking. I asked them if they have ever fainted. Do you feel like you're seeing stars or everything's like the snow on the TV when you're trying to stand up? How do you feel if you take a hot shower? Is it hard for you to stand in line or to stand still? You'll notice sometimes kids will be shifting and moving, and I mean like doing a dance when they're standing. They're trying to get their body is trying to get the blood flow back up. Ask the parents, are they always sitting with their feet tucked under them, or they always have their feet up on the couch, or when they're eating at dinner, you always telling them put your feet off, feet off the chair, or whatever. So those are some of the questions that I asked for orthostatic intolerance. Also at the last talk, and I will have these QR codes at the end here, there's an orthostatic questionnaire that I use as well. Sometimes, like if a patient is 10, 11, it may be hard for them to really understand the questions and fill it out. So I usually save that for my adolescent patients. Parents can help fill it out too, of course, but just depends on how you feel with your patients if they're going to be able to answer that adequately. Next slide, please. So this is or go ahead and to the next one. This is a patient. He's about 16 years old, and excellent health prior to becoming ill with COVID-19 in 2021, pre-Omicron variant, which is not good. He just had a mild illness, but afterward never really recovered. He one of those things where it would be, come into the clinic, sore throat, go into urgent care. Maybe he has strep, maybe he has a viral syndrome, and then, they send him home. Maybe he felt better for a little bit, then he's back. He never really felt well, but there'd be kind of this undulating course of, improvement, worsening, et cetera. But what really got him is he went to football practice in Tennessee, which is hot, humid weather. And after a week of football practice, he had a huge, huge episode of PIM. And he described it as feeling like he was pinned to the bed, like on a gravitron ride. I think that's how you say that. Gravitron. And mom was a nurse, and so she astutely recognized I need to ply him with salt and water, and she did, but he never recovered from that. And he ended up going from able to attend school, not, with difficulty, but able to attend school, to completely homebound, and at times bedbound. But when he first came to me, we did the NASA lean test, or the passive stand test. Next slide, please. So here's just, I won't read you all the questions, but here's that orthostatic questionnaire, and you can see he's mostly skewed to the right, and that's where the numbers get bigger and where their symptoms are more predominant. Next slide, please. And so what I do, if you're,
can I ask you for that symptoms? Does the symptoms improvement mean that they're getting better, or is that only symptoms at the time? Does improvements mean that they're getting better with time, or is it only just acutely of their symptoms?
With this illness, I tell people, even when you're improving, it's never a straight line up. It's a up, down, and now sometimes that trajectory is working their way up, but there's always setbacks, And I told somebody today, I said, I will never, and until we're in a different space with this illness, I never say anyone is well. I have seen people with long COVID that got better enough that they didn't need to see me anymore. But I would venture to say that most of them tell me I'm 90% better, I'm 80% better. I'm so happy to be where I am. I consider myself okay. But back to baseline, that's pretty rare for me. But what he would do is he would I think what he was doing was he was crashing and experiencing PIM, and he would have sore throat. Sometimes in PIM, I'll see patients get a temperature of 99, 100. It's not where in pediatrics we 100.4. That's our fever threshold. But when a kid has 100 or 99 for a few days, it's an inflammatory state that they're in with post-exertional malaise, and they'll oftentimes have sore throat or enlarged lymph glands, and they look like they have the flu. They look like they have strep, viral syndrome of the day, whatever. And they'll come into the clinic and then a few days and they're rest because they're sick, right? And the one thing about post-exertional malaise in kids, if you leave them alone, they will rest. Adults are more inclined to be like, I feel guilty, I feel bad, I've got to provide for my family. Of course they do. I'm the one responsible for feeding myself. I've got to go to work, and they push and push and push. But kids, parents push. The kids don't really push if they don't feel well. They'll lay down if you'll leave them alone. So he would rest and then he'd feel better. Not back to normal, but I feel better compared to that. So it was that kind of improvement. Does that answer what your question is?
Yeah, it did. I guess I have patients who feel better at one sometimes and then don't feel well the other times. And so, as you say, it's waxing and waning depending on that level of activity.
Yes, so much. And I call it an especially cruel disease because it's so unpredictable. You can feel great today and make plans for tomorrow, and you may or may not be able to go. It's just it's so unpredictable. So if you are lucky and you are near a center that does a tilt table test, and you have a cardiologist that sees children and does a tilt table test, fantastic, please send them. But if you're like me and you're in West Tennessee or most of the United States, you don't have access to that, or it's a year from now. And the funny thing is, I'm in the backyard of Vanderbilt, but they don't see kids. They don't see people under 18. So, even though I've got Vanderbilt right there, I can't send my pediatric patients to them. So this is a substitute or an alternative test. Dr. Peter Rowe, who I think you guys have had on, he highly advocates this test. He's awesome. He's from Johns Hopkins and has been doing this for many years. Many of if you look at my bottom, my references, they're by Peter Rowe. And he's such a great clinician in this area. But he talks about the passive stand test. I won't go through all the instructions because I have a QR code and you can read the instructions. They're simple. I will give you a few caveats when you're doing the test. Don't let the patient, part of the test is resting for 10 minutes. Don't let the patient have a phone while they're resting. And when you're doing the test, don't talk to them, or at least as little as possible, because if you're having a conversation, you may raise their heart rate, you may skew the results of the test. And that's not necessarily in the instructions, but it's a 10-minute, heart rate and blood pressure beforehand, let them rest for 10 minutes. Then we come in and do heart rate and blood pressure in this position every minute up to 10 minutes. So we did this test on this patient. Next slide, please. And he met criteria for POTS. So he immediately went from around a heart rate, I'm trying to read these tiny numbers, but a heart rate of around 81 and went to 110 when he stood up in that first minute. He kept climbing from there, and he went to a heart rate of 129, which was an increase of 51 beats per minute. He did not have a drop in blood pressure. He did have a little bit of a rise and a narrowing of his pulse pressure. Sometimes you will see that. And he just felt terrible as we were going along. As a matter of fact, we stopped it at 7 minutes. We knew he had met criteria, and he looked pretty rough. He felt really rough, and I knew he was going to crash. Like I said, he has severe symptoms, and I felt it was best to stop and let him complete the test at that point. Again, he had had symptoms about a year at that point, and he wasn't dehydrated for a year. The dehydration was not the issue. Next slide. And if you'll look at this one, this is this is not poor lighting. His feet are that purple. His mom's hand is in that picture on the right for comparison. But yeah, his legs all the way up to his knees were purple. And so, and that's what he does every time he tries to take a shower. Next slide, please. So how exactly, what can we do for this? So when I first started taking care of kids with POTS, I had when I was a resident, certain drugs I had used as a resident, but I didn't routinely use them in my practice. POTS was not something that I treated. It's been around for some years, but it's not been around the whole, like when I was in residency training, we weren't talking about POTS or orthostatic intolerance in children. So this was something I, had to kind of come along on my own. And so I started out tentatively, put my toe in the water, did a few simple things first. Some of the simple things you can do. One, think about what's the pathophysiology. Well, we want to increase and maintain their intravascular volume. We also want to improve their venous return, increase vasoconstriction, and then mitigate the effects of catecholamine release. Next slide. So the first thing you can do is counsel. Talk to the parent, talk to the school, talk to the kid. If, 10-year-old doesn't have much autonomy in their life, but a 15-year-old does. And so, you want to have them avoid hot showers, do cooler showers, or even better, get a shower chair. Don't get the kind that that your grandma has, but maybe you can get a teak shower chair that looks kind of like you're in a spa, and you get that at Amazon, and it's not too bad. So, you don't quite look like Granny, but not that there's anything wrong with that. Ask the school. Can they avoid the line? Can they, go sit at the table for lunch? Can, if they're in a speech class and they have to do a presentation, can they sit for their presentation? Can they have an opportunity a couple of times a day to go to the nurse's station? Let them, take a mat, lie on the floor, put your feet up at a 90-degree angle for 10, 15 minutes. Cool, ice packs and stuff can be helpful. But various accommodations, schools can really help if they, are informed and educated on this, because if you go to school, it's just, you think about all the sensory input and everything going on there. If you can do any of these accommodations, it will make their school experience so much more successful if they can go. Next slide, please. So the counseling on that, by the way, is you're not writing a prescription, you're just giving them good advice. So that's something you can do at the beginning if you're not comfortable with some of these things. Next is increasing intravascular volume. So the way we do that is increase their fluid intake and increase their sodium intake. In adults, I tell you 2 to 4 liters and 2 to 4 grams of sodium. In kids, a little different. If they're adolescents, those numbers are pretty applicable. But if you have an 11-year-old that's 70 pounds, or 80, it's a little bit different. So I start where they are. How much are you drinking in a day? Can we add some element or some other electrolyte packet to that? And I usually do 1 packet to 1 liter. Can you do 1? If you can do 1, then we go up and see what you can tolerate. Kids, I also find, especially when they're early in their illness, they have a lot of nausea. And especially when I guess part of it is they're getting up in the morning. They're usually exhausted because they didn't sleep well. And so now they're getting up, and it's the big rush to go to school. It's not, I know in my house, at least, there was never a calm, let's get up and go to school. Let's do this casually. It was always a big frenetic rush to get all the things and get out the door. And so I think all of that is just so much stimulus that it causes nausea. So sometimes they have a hard time getting that salt or the sodium and water in. So sometimes you have to go outside the box maybe and give IV fluids at the beginning just to kind of get them started on some things, and maybe tank up their tubing, their pipes, right? And then they can it's sort of like training wheels, and then they can fly on their own. Next slide, please. And this is another thing you can do. Again, no prescription required. Help them maintain their intravascular volume. If they're drinking the salt and fluid, let's help them keep it there. And so compression garments are great for that. Don't get too ambitious. 20 to 30 millimeters of mercury is optimal. You start getting higher numbers, compliance goes way down. And also, a lot of our patients are hypermobile and they're trying to get these garments on and they injure themselves doing it. So a lot of times with kids, I might have to just be happy with leggings, like athletic leggings. I'll tell them get kind of a small size for you so they're a little bit firmer. And then that can provide compression as well. But 20 to 30 millimeters of mercury is best. Waist high full leg compression is optimal. If you can't get them to do that, then try an abdominal binder. And then lastly, compression socks. And sometimes that's all you can get. Different climates, they say, in Utah or Tennessee, they say it was way too hot for that. We can't do it. We're going to pass out from the heat. So you kind of have to measure that. But in the wintertime, you can maybe get them to do that a little bit better. Next slide, please. So here's where we get into some pharmacology. So volume expanders, you're doing the salt or the sodium and water and salt and water, whichever you want to do, just make sure that you're consistent and make sure your patients know. And I always talk to them about sodium because sodium is what is on the label. And if I start talking to them about salt and it's different numbers for salt, then they start to get confused. So I try to just stick with sodium, but then my mouth says salt sometimes instead. Fludrocortisone is what we use for this. It's a mineral corticoid, not a glucocorticoid. It increases sodium and water retention. It's not effective unless they're drinking well. If they're not drinking adequate amounts, it's not really going to work for you. Side effects can be headaches. About 1 in 20, you'll get a little bit of a depressed mood. It goes away if you stop the medication, but I always let the patient and the parents know that so they can be alert to that and not miss that as a problem. Occasionally, if a patient is having a lot of nausea, I might give IV fluids. Size depends on how much I give, but I might give IV fluids a couple days a week for a couple of weeks while initiating the fludrocortisone, then try them off and see if they can sustain with the fluids and sodium. Next slide, please. Then we want to constrict those vessels, right? We want to, these vessels are more compliant. They're allowing blood pooling. So we want to have them squeezed so that we can get the blood back up to the brain and the heart. Midodrine is my favorite drug for that. So alpha-1 agonist, vasoconstrictor. It's one of the ones I reach for oftentimes first in my pediatric patients. But I also, let me mention this really quick. Whatever I prescribe, I start with the lowest dose possible, and then usually I'll even go lower than that. The lowest dose is 2.5, but you can with a pill cutter, you can get these broken in half, and I start with half, and it's 3 times a day, but I'll do it once a day for maybe a week, and then I'll do it again. Okay, now do it twice a day. Now do it 3 times a day, and I space it out because kids have this tendency. I don't know why, but it's also with adults too. Patients just have this sensitivity to medications. And I'll tell them initially, this is not going to help you. This little tiny dose I'm giving you is not going to help you, but I'm making sure it's not going to harm you first or cause you side effects that you can't tolerate. So we start there and just work our way up until we get to a dose that's helpful. And we try to find the lowest dose that gives them the best response.
Someone
you
asked
can also, go
someone
ahead.
asked if they have asthma, does it cause bronchospasm? I
It
don't think
doesn't.
so. It does. Okay.
Beta blockers do, and I'll talk about that in a minute. That is one you should be concerned about. But actually, it's fine. It's fine. The trying to think, they can have urinary symptoms. They'll get these goosebumps, pins and needles, feelings, and typically those will go away. Again, it's why I start so low. And again, I learned this the hard way. Started out gangbusters with my kid and then realized, oh, we shan't do that because, all the side effects occur. So go slow and you kind of get them adjusted to it easily or more, it's more gentle, I should say. Now, stimulants can do this, and I don't give stimulants just for POTS, but if they have ADD or have another reason for it, I might use that one to cover 2 birds with 1 stone. Same with SSRIs, SNRIs, they can be helpful. Not my favorite drug for this, but if they have depression, it might be a nice adjunct to what you're doing, maybe in another drug class. Next slide, please. So the next one is to think about, these kids that are running around. Well, they're not running around, but they're walking around, sitting around with a heart rate that's very uncomfortable, and that feeling of their heart pounding out of their chest. So beta blockers are good for that. And again, I start really low. Vanderbilt did a study, and they came to the conclusion that a better dose in pediatrics was 10 milligrams 3 times a day. I actually sometimes I'll start with 5 and go low like that. And again, it depends on the size and age of the child, but in general, if they're 12 and 100 pounds, then that's kind of where I start. That helps a lot of things. It can lower the heart rate. It can help with that sympathetic overdrive, and you have patients that will love you for that. Now, you also have, kids, their blood pressure. You got to watch their blood pressure. So will their blood pressure tolerate the beta blocker? Beta blockers can cause fatigue. So, I have to think about that and weigh that and see how they respond. And sometimes you have to, use a low dose. Sometimes I end up using a low dose of 2 or 3 different things, which is, for me in pediatrics is not my typical. Before this illness, before I started treating this illness, I didn't go around giving patients 4 or 5 meds. But when you think of quality of life, sometimes you do need to do that. But sometimes I'll use a low dose of beta blocker, but then also use a low dose of midodrine. Ivabradine can be helpful. Like if they have problems with keeping their blood pressure, if they have lower blood pressure, ivabradine can be helpful for the heart rate, but it's not so helpful with those sympathetic overdrive symptoms. So if they're that teen that you go in the room and you look like you've scared them, they're probably going to appreciate the beta blocker more than the ivabradine. As you pointed out earlier, this is a patient who has asthma. They may not tolerate this. Or if they have, a lot of allergy symptoms, and if they have anaphylaxis at all, I wouldn't write a beta blocker. Pyridostigmine can be useful. Clonidine, guanfacine, again, those are 2. The clonidine, guanfacine you may be using for ADD. So it's something you can use again to hit 2 birds with 1 stone. Next slide, please. So which drug win? Again, this is something you get a feel for as you do it, but and a lot of times I really struggle with which one should I do? They have the sympathetic overdrive, but they clearly can't stand up for very long. Should I do midodrine? Should I do beta blocker? But midodrine or fludrocortisone, if they have low blood pressure, those are definitely the ones to go for. Midodrine, fludrocortisone. If they have that sympathetic overdrive, a little touch of beta blocker or clonidine can be quite helpful. Resting tachycardia without that sympathetic overdrive, you might reach for ivabradine. Anytime I can help 2 things with 1 pill, such as chronic headaches, use a beta blocker. Attention issues, again, the stimulants, clonidine, guanfacine, on and on. Ligamentous laxity, and we don't have time to go over every single thing, but a lot of our patients have hypermobility. And if they do, midodrine can be a good choice. Constipation, pyridostigmine, etc. I'm going to have you go ahead and go to the next slide, please. And I'm going to start talking about mast cell activation, switching gears a little bit. And then next slide. So exactly, first of all, I'll tell you what the connection is, and I'll tell you what it is if you're not familiar. So acute COVID-19 illness, you've all heard this 100 times. It causes a cytokine storm. There's rapid proliferation of hyperactive T cells, macrophages, natural killer cells. We have overproduction of cytokines, chemical mediators. SARS-CoV-2 can activate mast cells. The cytokines and chemical mediators also activate mast cells. SARS-CoV-2 connects to the ACE2 receptors on the mast cells. Then, when this persistent inflammatory state is going on, it can activate mast cell genes. This makes the mast cells overactive, and it can go on past the acute infection. Additionally, autoantibody formation can occur, and this can interact with mast cells, again, activating them. And some people seem to be more susceptible to this. Next slide. So what are mast cells? When I was in residency, we talked, go ahead and go to the next one, please, sorry. Mast cells are white blood cell. They're found in connective tissue. They can activate in less than a second. They're what cause anaphylaxis, like to venoms and foods and things like that. And there's mastocytosis, and it's a clonal disorder that occurs in kids. And that was kind of all I learned about mast cells. It was literally 5 minutes out of a lecture in medical school. That's all we got. And so turns out mast cells are can cause quite the mayhem in our body. So they're a type of white blood cell. They're located in connective tissue. So our blood vessels are made of connective tissue, so they're all throughout the body. They're in lymphatics, skin, mucous membranes, GI, GU, lungs. They're where our body interfaces with the outside world. They're like little soldiers patrolling, looking for anything foreign. In mast cell activation, go ahead and go to the next slide, please. In mast cell activation, these little soldiers have just gotten all hyped up, and they're trigger happy, and they're ready to, what's normal for you all of a sudden becomes a trigger. And some people who have severe mast cell activation can really be triggered by some common things that can be very difficult for them to interact with their environment. Even temperature. So like water has to be, if it's too cold or too hot, it can activate them, which can be very limiting. But in general, again, in peds, when I was taught, we talked about mastocytosis. I'm not talking about that. That's the clonal disorder, production of too many mast cells. This is the mast cells we have are just ready to roll. Something normal comes through and it's like, oh, this could be an attack, and off it goes, releasing its mediators. Next slide, please. So what happens when they're exposed to a trigger or an allergen, they become activated and release inflammatory chemicals or mediators. These mediators, there's been over 1,000 identified. They're such as histamine, leukotrienes, prostaglandins, platelet activating factor, tumor necrosis factor alpha, heparin, tryptase, all these different mediators, and they can do different things. Additionally, those mediators send out signals to affect other areas of the body. So you can rub some cream on, and next thing you know, you could have GI symptoms, which sounds really strange, but you can, because they can signal those other mast cells. And I'll show you an example of that in a minute. Next slide, please. So what are the triggers? Again, about anything. Medications, antibiotics, NSAIDs, opioids, but any medicine, excipients in medicines. It's not just the medicine itself, it's what's also in the formula. Foods, venoms, heat, cold, temperature extremes of any kind, pressure, vibration. So riding in the car can cause a problem for people. Perfumes, scents, chemicals. If somebody tells you someone, next door had perfume on and it bothered me, you think about mast cell. If every time you give a medication, they have a reaction, think about mast cell. Stress can do it. There's corticotropin releasing hormone receptors on mast cells, which explains so much. Next slide, please. So what are the symptoms? This is going to sound familiar to you. Headaches, fatigue, bone pain, itching, rashes, hives, headaches, chest pain, shortness of breath, GI symptoms with bloating, constipation, reflux, diarrhea, easy bruising. Remember, heparin was one of those mediators. Cognitive dysfunction. Sounds a lot like long COVID, right? But those are some of the symptoms of mast cells. People have mast cell issues. Again, unpredictability. Today, you can eat X, Y, or Z, and tomorrow it may be a completely different story. And it has to do, I think, with kind of your mast cell bucket. How many things have you been exposed to in the last 24 hours? So today, this is okay, but tomorrow it's not because your bucket was already full. Next slide, please. So this is an example of a mast cell skin reaction. The first picture is from this patient had a stellate ganglion block, and she had about 6. And every time she went, I'm laughing because it was just a losing battle. But the first time we were convinced, it was the betadine. It was the betadine. Surely it was the betadine. So we'll just not do betadine next time. No, wasn't the betadine. Then we eliminated everything. No tape. It was paper tape, alcohol prep, nothing. There was just nothing. And still she would break out. And sometimes people break out from plastic or from a puncture and those kind of things. Just could never get it worked out. Then the next slide, on the other side, she had severe POTS, and she had a PICC line for a moment. And this was the kind of the very beginning of the rash. And it was the adhesive, by the way. The adhesive on PICC lines can be awful. But by the end, this rash covered her whole body. So it wasn't just where the trigger was. These mast cells were proliferating, signaling others to be recruited in the fight against this horrible adhesive. And it was going to fight to the death. So finally, the PICC line had to be removed. Next slide, please. Okay. First thing to do is identify and avoid triggers. No adhesive for her. None of that. Avoid things that you know are triggers. Sometimes it's a challenge to find the triggers, right? I mean, if you ever listen to Dr. Larry Afrin, he's one of the most knowledgeable people regarding mast cell activation syndrome. And he always talks about identifying and avoiding the triggers. And I'm like, well, that can be really hard when you think of all the exposures you get through in a day. And he's brilliant. And I'm sure he has a method with his patients. I need to sit in on that and listen. But I know as living with this, it's hard to identify the triggers sometimes. Because again, you're exposed to so many different things in a day, it's just hard to figure it out. But if you know there's something that triggers you, if you know there's a food that triggers you, don't do it. I had a patient this week. She was an adult patient. And she said she knows gumbo triggers her, but she said, I'm going to eat it anyway. So we'll just eat a smaller bowl. At least do a less dose of it. Maybe you'll do a little bit better. She was having none of the avoiding the trigger. Next slide, please. I was trying to think if I told you the triggers, but I did. Yeah. Okay. So sorry about that. Pharmacological interventions. So here again, kind of nice. You can start them with things that are over the counter. And that it makes me feel a little bit easier when I'm writing medications and things that are a little bit off book, right? There's not even criteria for mast cell activation syndrome in kids. I've tried to find it. I have found different things from like the Asthma Allergy Society, mastocytosis, or I can't remember. There's a society with the people who are in the allergy field. And I've listened to lectures from experts and they have talked about using the adult criteria, but there's not really hard and fast. Here's how we do it in kids. So again, just try to go easy and slow. But again, I also have to weigh that with quality of life. If you can help them and their quality of life is really poor, then I'm going to be a little bit more aggressive. So H1 and H2 blockers. H1 blockers, you have your sedating and non-sedating. I generally try non-sedating first, but sedating sometimes can be helpful for brain fog, oddly enough. Mast cell stabilizers include cromolyn. Ketotropin is something you have to have compounded. We also have leukotriene blockade with montelukast and zafirlukast with all the typical warnings. Sorry, I'm trying to get through this really quickly so I can have time for questions. Last slide. Basically, what I'm telling you here is support your patients, listen and believe them, ask them what they want to work on the most, what's bothering them the most, what can you help them with the most. The biggest thing you can do is be their advocate with schools. Schools are really important. And your best friend can be at the school and with the school nurse. Collaborate with them. They can really be an advocate for your patient while they're in school. You also need to get the parents on board, make sure that they understand and are educated. Explain to them there's no quick fix. You're not going to be able to fix anything overnight, but you're there. And the other thing is, this disease, there is no one size fits all, and you don't know which way to go. Sometimes you're surprised at what helps and surprised at what you thought would help didn't. So sometimes I don't like to say trial and error. It's trial and pivot. If this didn't work for you, then we're going to cut it and move on to the next thing. And, the good thing is I have a bunch of things we can trial for you. So, hold their hand through this illness. Thank you. Sorry, I'm going over.
Thank you. So Yvonne asked, are there allergy tests that you could test for mast cells activation? Identifying triggers?
That's not really that tells you more typical allergy symptoms, but it's not really for mast cell. And, you can get mast cell mediator test. they're really hard to get done correctly. You can do, and there's, you can get histamine, methylhistamine, PGD2, tryptase. And the funny thing
Yeah.
is tryptase is the one I'm least likely to find abnormal. But that's always the one that's mentioned. But I get histamine, methylhistamine, PGD2 is one that I oftentimes see in kids. I pulled a couple. I have a lecture where it's just mast cell activation. And I tried to find and here's the other thing. Guess what? They're not necessarily pediatric values for these. So you're still kind of, I think, it looks elevated. It would be elevated in an adult, but we don't know that it's elevated, if that would be elevated in a kid, because there's been no trials for that. Again, this is sort of uncharted territory. But if the symptoms, if someone has a lot of symptoms of rashes, GI distress, allergies, runny nose, sinus symptoms, and things like that, it's worthy of a trial of H1, H1H2. Again, most of the things that are on that list are things a parent can get over the counter anyway. And if it doesn't help, then okay, stop. I've tried to remember if something doesn't help, I don't continue it. And this requires doing one thing at a time, which is sometimes painful, because you can only do so much. Doing it in that order is very slow. But if you do it methodically, then you don't end up with a patient on 8 medicines. Just try the things. If it helps, then you can keep it. If it doesn't help, then come off of it.
What's your sense of the ketotifen? Because in
Yeah.
the US, it's only drops for the eyes or ear.
Right. I use ketotifen all the time. Ketotifen is it's used in Europe orally. It's a mild antihistamine, but it's also a mast cell stabilizer. And it's one of the, it's all anecdotal when I say this, but ketotifen is a fairly effective medication. Nothing's 100% with this illness, but it's one of those that I'm fairly reliably can get improvement with. So I like ketotifen.
How do you get it?
You
How do you
have it
get it though?
compounded. Yeah, compounding
Oh, okay.
pharmacies can get it. And with adults, my dose is usually 1 to 3 milligrams twice a day. So, and I probably would mostly I'm steering more towards 16, 17-year-olds, older adolescents with that because it's off label, obviously. And I'll do like a half to a whole milligram twice a day, but you can get it compounded at a compounding pharmacy.
And then there was a question, can medication hypersensitivity intolerance be presentation for MCAS?
Yes, absolutely. Again, in adults, because they've been exposed more, but if I see a list of 6 allergies and you start asking what happened, well, this one made me black out. This one, this one gave me hives. This one made me, get manic. I start thinking about excipients and issues with mast cell. The person who also has on their allergy list perfumes, dyes, all those things. And so in kids who are super sensitive, I mean, if you're 8, you haven't been exposed to so many medications and have all those problems. But with kids, a lot of times what I see is GI issues, rashes, flushing, easy bruising. And I found for this illness, both in kids and adults, in kids especially, look heavy for both of these comorbidities. It's, I said earlier, I cannot think off the top of my head of any pediatric patient with this illness that I have that doesn't have some form of orthostatic intolerance. I can think of some that I cannot find. I'm like, I bet your mast cells are overactive, but I can't find evidence of it, or I'm not sure if I'm not sure fatigue can be a symptom of it, but I'm thinking that's more of if that's it, then I'm not going to blame that on mast cell. But look hard,
Yeah,
and you may find it.
yeah, Dr. Rowe, who was on, he actually didn't have any there's no set criteria in his mind for mast cell activation. He just said that if the symptoms fit, then he would say that it's activation.
Yeah, and I'm not calling it mast cell activation syndrome per se, because that maybe at least in adults, it's a certain criteria. Just saying they're overactive, and again, sometimes when I'm treating and I'm like, I just can't seem to, I'll tell you a strange story. I had a patient and she was diagnosed with psychogenic seizures. She had been to a children's hospital, had seen neurology, had been multiple times to the ER, and they weren't normal epileptic seizures. They didn't look like normal seizures, but she was having these events. She fell and cut her head twice, requiring lacerations. This wasn't just histrionics or anything. And she was one of my first patients in this. When I started seeing patients with long COVID, ME/CFS, she was one of my very first patients. And I had sworn I would start easy. I'm going to just see easy patients at the beginning. Once I get better, I'll go to the next one. No, she was one of my first patients. And she came into the office with these psychogenic seizures. And I stepped out of the room and I thought, I don't know what to do. No idea what to do. But she had some GI symptoms that sounded like mast cells. Like, I think I'll try a little gastrocrom for her GI mast cell symptoms, activation symptoms. And I did. And when she came back a month later, she had not had a seizure. And she had been having these episodes 10 times a day, completely gone. And after that, going forward, she had one or two every month or two, but that it was markedly decreased. And it came from mast cell treatment.
Well,
So,
could I ask you, so is it worth doing any levels? Do reduction in levels mean that you're working on improving?
Reduction in levels doesn't matter to me. That doesn't really tell you anything. Reduction in symptoms will, though. But you can do, I get the labs. A lot of people say, I'm not bothering. Half the time they're negative. I'm just not going to do it. I do it because of the science. I'm just like, let's prove it. If I can prove it, then when you go to the ER, wherever, maybe they won't dismiss you completely out of hand. So I like to get the levels. I like to see, plus it makes me feel good. Okay, I am on the right track. But part of the problem is the collection of the samples are very tricky. I can't remember which ones are which. I always have to look it up. But some of PGD2, I know, you have to draw it in a cold tube, put it on ice, and refrigerate it, or put it in a refrigerated centrifuge and run it cold. But that's the only way it works. If if the people come and pick up the blood and transport it and they let it get warm, it's going to be useless. If they don't draw it in a cold tube, not going to work. I was drawing it at my clinic for a while and I was like, oh, well, that's why none of them came back positive. We weren't even drawing it in a cold tube. I didn't know. And I learned from that mistake, right? And in Salt Lake City, I seem to get better ones because there's a lab called, what is it, Clayton? ARUP? I don't know if they call it ARUP or ARUP, but anyway, that lab I've been successful with them. And I've been surprised because so many people say, oh, they never come positive. I have had in kids, a surprising amount come back with a positive result. And again, that at least makes me feel like I'm not totally off base. It also helps the patient because sometimes they're like, the patient with that rash, didn't think she had mast cell. And I was like, I don't know. I think you kind of do. And she, no, I don't think I do. Well, then we did all this. She's like, oh, okay, I have mast cell. I'm with you now. I understand. But it helps them to understand too. Yes, okay, I have evidence. Plus, it makes them say, huh, everybody kind of dismisses me, but look, here's the lab that's abnormal. In the typical, I call it kind of the long COVID ME/CFS world, and then there's the world of everybody else. If you're in this, if you have a sick kid, if you have patients if this is your full practice, you kind of live in this bubble. But normal patients don't want abnormal labs, but patients in this group like some confirmation, like some validation that their symptoms are matching something, because so many times they end up gaslighting themselves because they're told, oh, you'll be okay, pat you on the back. Here's your note to go back to school.
there's a question is like, what is your approach with presentations without classic allergic manifestations or mast cell-driven neuroinflammation?
Wait, let me find that.
Yeah,
Um,
on the chat.
So you're saying if I have a patient who doesn't have mast cell or who doesn't have the classic presentation?
Melinda, could you clarify? I think she would probably say it's classic presentation.
Okay. Okay. So again, like my patient with the the non-epileptiform seizures. I don't like calling them psychogenic seizures. It's icky to me. But I did that with her because she had some GI symptoms. But sometimes when patients have multiple symptoms and I'm not sure that it's mast cell or is it dysautonomia, is their heart rate up after they eat because they had blood pooling with their meal, or is it because something they ate triggered their mast cell? Then I might do a trial of an H1, H2 blocker and see, does that make your symptoms better? So a lot of it is trial something, see how they respond. And oftentimes you'll get a funny response. I have a patient, have several patients that I use the ketotifen eye drops, and then I also use cromolyn nasal spray, and that'll take care of their sinus symptoms. A lot of times, their allergy sinus symptoms, you don't even have to go with something oral, just use those. And I use aloe. Aloe is ketotifen without any preservatives. And so that's my preferred on that. Because so many eye drops burn and there's preservatives in them, and so ugh, uncomfortable.
Okay.
Yeah, and talking about neuroinflammation, I mean, that's thought to be glial cells, mast cell activation oftentimes is a part of that. That's I was going to say that's another symptom of mast cell is brain fog, brain fog. And so I work on neuroinflammation with things like LDN or, I said I have no disclosures. This is not a disclosure. This is not my drug. This is not anything I manufacture, but I use something called Neuroprotect. It's a supplement with luteolin, rutin, and I'm blanking on the last one. It's in my talk.
Rutin.
Yeah, rutin. Thank you. Rutin, luteolin, and quercetin. That's it. And it's Neuroprotect. And I like it for kids. First of all, it was developed by a guy Dr. Theo Herides, who is also the other guru in mast cell activation syndrome, as is Dr. Larry Afrin. And he developed this without any excipients in it. It's in a base that makes for better absorption. I like it in kids a lot. There's a formula with drops, and so I can start them on drops. And you can put it under your tongue and let it absorb. Or I even sometimes have mom put it in applesauce or something like that. And so it's something that's easy to dose with kids. And it's, it's not like giving them a drug. It's giving them more of a supplement. And so I like that. It can also help with neuroinflammation. And I give it for general mast cell activation, but I also give it for, especially if they have brain fog.
Okay.
And also, by the way, cromolyn nasal spray can help with brain fog. Dr. Peter Rowe may have mentioned that too, because he's the one that told me that.
A lot of patients also find in physical therapy, if they put cromolyn sodium, the gastrochrome or nasal chrome on the skin prior to adhesives like KT tape or other things for hypermobility, that they let it dry, then it helps prevent the reaction to the adhesive.
Yep. You can get Vanicream and put cromolyn in it and mix that up and use it as well. That's another option. If you need to get a way for it to spread and absorb.
All right. Well, wonderful. I'll give it just a second to see if anybody else has any questions. and it doesn't look like anything else is coming through. So I just want to thank Dr. Hoppers for coming and presenting for us again. We appreciate you being here. And Dr. Powers, who's also presented for us and coming in with the assist, especially in the chat section. So thank you everybody else for attending today's session. Remember to complete your evaluation form when you receive it. And then if you're interested, our next session is on August 11th. Topic that day will be long COVID, vascular damage, and microclots. We hope to see you there, and thanks again and have a great rest of your day.